Emily, you're with us, and you're from Stockholm in Sweden, and we're very glad that you're with us now. And you will be actually guiding us through what incentivized us is when we read your Lancet paper on how the mental health is impacted or so by this whole COVID situation or Corona situation that we're all in. And you had some ideas in that paper, and we know how you have additional ideas on top of that, developing your career. But we were very happy that you said yes to be willing to this panel. You are also part of the Odessa team, the NATO team. So I'll, a great pleasure to give you the opportunity to share your ideas to this traumatic stress panel.
Thank you, Eric. Thank you for that lovely introduction. Am I okay to share screen now?
You are able to take the share. Yep.
Wonderful. And Isaac, I'm so sorry about the tech glitch, so I was late, but I have so much enjoyed your talk, and I would love to talk more later. Can you all see my screen okay now?
It's coming up.
Yeah, great. If there's any delays or a tech glitch, just flag and I'll sort it out this end. So I just think it's brilliant that we're able to kind of get together and discuss. Eric and Joseph very kindly asked me to talk about a paper that we published fairly recently, for some unknown reason, and I'm so sorry about the tech. There we are. Now it's forwarding, and so thank you for sharing. And I'm really excited to be part of a dialogue here. I understand we've got many countries and particularly early career networks involved. So what I wanted to say in my talk, once here are my disclosures, was really that this is a start of a conversation, because as ever in trauma, it's not just a single event, but an ongoing situation. And Eric's asked me to talk about the pandemic. I'll talk about what we've done, but really try and reflect about how we go forwards in terms of a dialogue. So I don't think we have clear solutions, but I do think we need to find better ways of asking what the right questions are to do, rather than just jumping in. And I'd love your critical comments on this later. So you know where I'm coming from. I'm a clinician. I've also got a strong interest in cognitive neuroscience, and I'd probably badge myself today as a mental health scientist interested in psychological mechanisms. I'm actually interested in all sorts of mechanisms, and that's why I love being part of ECNP, pharmacological, you name it. But I think there's a real role for psychological mechanisms when we're dealing with digital technologies and trying to work in a pandemic. And by mental health science, what I simply mean is really kind of where Isaac's talk led us to, which is actually we need to connect across loads of different disciplines at the same time. So what not distinguishes us is our scientific backgrounds, but maybe what unites us is a goal. Like, I think, Isaac, what you're talking about is implementation science meets translational neuroscience, but we can talk more about that later. So the paper that we published was in April, and if you're anything like me, April feels like a really long time ago now. And it was around this mental health science kind of multidisciplinary way of thinking in terms of research priorities. And I'm very, very grateful to a whole host of co-authors here from very different areas and disciplines. And we did do something pretty quickly. It was only a month after the WHO announced that we could characterize this as a pandemic. And at the time, no governments were prioritizing mental health except Australia. And so we were very much supported in this endeavor by a combination of the Academy of Medical Sciences of the UK and also the mental health research charity MQ, Transforming Mental Health Through Research. And we were doing this work just as the UK and it was going into lockdown. Here in Sweden, we weren't. And this kind of slightly reminds me of the Odessa journey. Like, how do you work together at speed? And I guess what we were trying to do in this work was put together diverse backgrounds and encourage a way that we could debate quite vigorously amongst each other. And we did that by meeting every single day after breakfast for a while. And from the very beginning, working with people with lived experience of mental health issues during the pandemic as part of our core writing team, but also doing 2 surveys of almost 3,000 people in together, about 1,000 with interviews and 1,000 more on 2,000 online, trying to look at both how people were describing the impact in terms of their negative mental health, but critically what was helping in terms of coping and improving well-being. And I guess those 2 sides in the world that we're in, with an interest in trauma, as Isaac said as well, resilience is as important. So that was, and the survey results are also freely downloadable, as well as the paper itself in the Lancers Resource Centre. So I'm going to give you the big picture in just 2 slides, and then you can go take a coffee break whilst I go through some of the details. No, joke, Eric. I will sort of go into those more rapidly, but I suppose where we'd got to in April was that, of course, not everyone's going to be affected. It's not a scaremongering story, but of certain more what we might call vulnerable groups, they're the places to focus research resources. And remember, this is about a research position paper. So I guess the bottom line is about taking a stressor like an ongoing pandemic and seeing that as a way as it pushes apart the mental health inequalities that already exist in society. And we're a part of a European network, but I mean that in all senses globally. And a lot of the discussion is obviously with colleagues all around the world. So when we're talking about vulnerable groups, we might think about groups who perhaps already have a mental health history, but also vulnerable in terms of the kind of interventions we use in a pandemic, making it excessively vulnerable. For example, young children who are at risk, being then affected by staying with in difficult home situations, or elderly people being isolated, or minority groups. And we can continue that list, and there's also a very important thought going into that. And there's also groups where we might obviously put up flags for risk, such as patients themselves who've been in more acute risk, such as being in the ICU, and people who are helping manage on the front line. And something about working on a multidisciplinary paper is that ability to try and think, how can we think both at an individual level and what we might need, how we might be thinking more in terms of public health, social, community level, but also, and critical to ECNP, perhaps more at a biological and neuro level. So in the paper, and at the end I'll put a link where you can download it for free if you're interested in taking that further. We've gone through examples, and this list is just continuing. We had 21 letters sent to us within about a week or so about particular groups for which researchers and those working in the area of mental health may wish to think particularly carefully. And of course, with the caveat that many people be resilient, but it's more about trying to identify where to focus and think preventatively as well. And this broad brush approach, we're thinking about very general research priorities. And when I said at the beginning about surveying, both in terms of what was difficult and also what was helping with coping, I guess throughout the paper, those 2 aspects are mirrored. So what are the effects on perhaps long-term outcomes we've seen with pandemics in the past, such as increased rates of suicide after SARS? That's something we could be mindful about, what timings, how we're looking at that. It's not an acute effect, it might be a more chronic effect, but also what's helping create a more optimal structure for a so-called mentally healthy life in the wake of something like physical distancing. So trying to think about both. And as I would say repeatedly, one of my interests is also perhaps not just counting what's difficult, but thinking more mechanistically how to intervene, and what might, if we're designing interventions in the face of an ongoing pandemic or repeated situation, what might that look like? And I guess another aspect to this is thinking again, we've got the sort of biopsychosocial, as you were, so from the more psycho to the social aspects, we might want to think about things like health messaging. we might want to think about things like media consumption, and so on. And we've also written about, I won't go into this in detail, the sort of actual more viral effects on brain and biology. But I guess at a meta level, and important for all of us going forwards, is how to maintain high research quality standards. And I suppose everyone knows now that all the journals are complaining about a flood of very rapidly rushed papers that perhaps don't meet the usual standards. So something about encouraging us all as a community to, despite that sense of urgency, try to be careful still about our study design, ethics, whatever it might be, open science. One area I think that's really important, and I mentioned earlier, is thinking about including not only our individual particular research perspective as an academic, but including from the beginning people with lived experience during this time. And I think that's important in the questions we ask and the interventions we design. And so we put a lot of effort into that, which was really pleased to see was picked up, for example, by the Nuffield Council on Bioethics. Even when things feel rushed, that it's useful to make sure we continue that public involvement, and this is a foundation that happens to be particularly useful and work with us on helping us think through that process, the McPim Foundation, and Thomas was one of our co-authors in this discussion. So I think we're probably in a situation where the discussion is not just whether there's one winter wave, but perhaps how long this is going to continue and what might happen after it. So I think we have to pull back and think more broadly as well, how we keep a strong research agenda and what are the key questions to ask. So bold questions that I really hope are a subject of debate. Everyone should have, be thinking onwards about how to co-create priorities, but perhaps things that will really stand the test of time is trying to think, the sorts of things that Isaac was talking about, how to recognize vulnerable individuals, but also how to intervene in the simplest ways possible, or mechanistically, how to identify what can make a difference, even if that doesn't look like what we're currently doing, and to consider interventions at different levels would be really important. So that was the bottom line. We need some kind of joined up thinking, a robust mental health research response to the unfolding situation. I've already mentioned this point. Perhaps one part of that is not just counting what's difficult, but thinking together what we might do about it. One thing that hasn't perhaps received a huge amount of attention in our field, but I think is really interesting for this pandemic compared to other pandemics, is the backdrop that we're under, particularly in the early days of 24-hour media exposure. For anyone who works in the field of anxiety or emotion, it's no surprise that ongoing repeated information can change your emotional levels. But I think this might be something where we really under-researched, and mental health scientists could do something interesting to think about how we both think about media, which helps us understand the health risks and perception of risks, but doesn't tip us over into distress and anxiety. And for this group, you'll be well aware of things like media trauma reporting guidelines or media guidelines on suicide risk and suicide reporting. I guess the issue is that there's an enormous amount of media with traumatic content at the moment, which perhaps in and of itself at an individual level isn't the main issue, but perhaps a more sort of social level of thinking about mental well-being is something that's worthy of consideration. Eric asked me to reflect on trauma, and while the position piece isn't specifically about trauma, it did pull some out. And one of the things that we pulled out as a priority was those people who are more repeatedly exposed to trauma than they would have been otherwise, such as frontline medical staff, and in particularly those working directly with COVID patients, for example, in the ICU. And this has been a subject of wide international discussion now. So we've got a lot of the research to date is very cross-sectional, but one can start to think across different countries, and I won't go to this into detail, we're seeing reports from first China and Jordan and Italy and so on and so forth, looking at reactions to people working on the front line and reports of increased mental health. Where also some data is looking at who might be more vulnerable, such as new staff or those with an infected family member. And I guess to make this more concrete, in this kind of example, we might be talking about staff who are working with more repeated trauma exposure in the line of work than they would be normally, such as the tragic deaths of a patient, or there's a lot of discussion around how difficult it's been to manage perhaps in the situation we've had with relatives not being able to be visiting, examples of violence against staff, or difficulties with hospital care. So I'm just thinking from a trauma network perspective, we're not saying that per se blanket trauma, but there may be specific events. As David Nutt just said, it's trauma is a dose-wise response, and that's something we've known for a long time, and that might be something we wish to keep an eye on. But it's not to say that none of these things weren't a problem before to COVID. Of course they were, and it's long been cited, but it's a rather giant torch to shed on the fact that people are being put under enormous pressure now in terms of trauma exposure. And it is something perhaps this network could be thoughtful and mindful about going forwards. And I keep coming back to saying, and I put this, as Isaac flagged as well earlier, about resilience. It's not going to affect everybody, but we're talking about those people who it does affect. So it's important to know what does help.
Emily, if I may, at this moment, is it helpful, or has it been helpful to look actually at the Sars epidemic as it was in Toronto for understanding what the mental health impact for the ICU professionals would be in this current day and age?
Well, with the SARS epidemic, we drew on that very strongly in thinking about the need to look at suicide in particular, because what we saw there was not an acute escalation, but as it progressed, a longer term risks. But of course, from a research perspective, you want to be working now to think about those. With SARS, they weren't affected, the numbers are so different, and the pressure on the healthcare systems is so different. So it can inform our thinking, and I'd love to hear about more specific examples. But at the time we did this research, there wasn't an enormous amount. But unless you have something in particular that you're thinking about, Eric, just because the scale is so different.
No, actually, I was thinking of the long-term outcome, because we see now the immediate impacts in the first couple of months. But from SARS, we could learn about what the long-term impact is on these healthcare professionals, and as well as
And as I said, one of the long-term impacts we've learned from SARS more generally is the things that are on the horizon which the community needs to respond to. So after traumatic events, of course, one outcome are symptoms such as post-traumatic stress, but there's many other outcomes too, such as depression, such as burnout, and such as, in its worst case scenarios, suicidal behavior or completion. And these are exactly the kind of things that need to be on the radar now to get beyond, if one might think about it, what we divide up in the paper is acute reactions, intermediate priorities, and long-term priorities. And I think we're now in we now have to think about the medium term and longer term, exactly as you say, and be prepared that if there is a significant risk, now is the time to be doing and thinking about research and communicating over how we could proceed wisely, particularly given because the number of episodes or doses of exposure seems to be so much higher.
Emily, do you mind if I ask, one of the things that I found both challenging and exciting about, research in the area of traumatic stress related to COVID is the vast heterogeneity in the nature of the trauma exposure. And what the outcomes would be. I think about my experience, and I live in Brooklyn, and we spent about 3 months just literally 24 hours a day hearing sirens. First from ambulances, and then there were riots, and there were police cars being burned down the street, and it's all kinds of stressors. And I talked to and then I'm managing school with my young kids and all this craziness. And my parents, who are in the suburbs of Chicago and are older and retired, they feel totally isolated. They're scared of getting sick. They're at much higher risk than I am, but also they just, are just sitting in their house and, kind of scared, but also very isolated and alone. And I just think about all we know about we have bereavement outcomes, we have real stress, where people get really sick and have an immune response. How do you think we can build in that kind of understanding of the heterogeneity of the trauma itself into this research?
I mean, I think you've answered your own question in as much as that's something one can build in. If you actually, all of the things you've said were actually in some of the earlier panels that were probably hard to see. So I don't think that being isolated is the same as a trauma. I think that may be, in a way, to simplify things, that there was a lot of discussion around what are the right questions to be asking in a pandemic. So I think we're pretty stuck about thinking about diagnoses and trauma as it is. And I want to just pull back a bit and say, well, what are the questions that we could ask to make a difference? And if we start at the opposite end, the reason I focused on vulnerable groups rather than diagnoses is because, as you say, an example of your parents, if you're isolated, you may think about loneliness, or you may think about other constructs, and therefore the kind of intervention that you might want to derive around that might be entirely different than a trauma response. So I don't think it's helpful to think about the pandemic as a trauma in the slightest. I think it's much better to think, and is to approach it from the completely opposite end, which is to think, what's going to help in the longer term sustainable mental health under pandemic conditions? Who are the vulnerable groups, and how can we work backwards to design pandemic fit interventions around that? And maybe that's throwing diagnosis out the window and dealing with loneliness, for example. So that would be one radical solution. Coming back and approaching it more like from a science end, I guess the reason I put up examples of frontline staff is that it's not saying that the job is traumatic. It might include all those things, including isolation. There's many nurses who are having to work in isolation from their families due to risk. And I think what you want to parcel out is the nature of what the traumatic event is, and think about those. But that's why it requires working from, I think, from really pulling back, slowing down and reformulating the questions. And the worst thing we could do is just tons more traumatic stress research. That's probably the least helpful thing to do right now. I'm going to stick my neck out. I think what we ought to do is reframe the questions and approach it like clinician scientists who are all working together across different perspectives.
If I may, at this moment, because you're taking my brain, we were all in Odessa. Not everybody was in Odessa, but I'm blocking on the name of the presenter here. Actually, in the first couple of weeks, as the pandemic was increasing, and we had some communication also with Simon Wesley. He says this is going to increase in a lot of unrest, social instability. And he preluded to something, he didn't call it this way, Armageddon or so, but this is going to be catastrophic or so. And I don't know whether Black Lives Matter and stuff, that it just coincided at this moment, that the social instability and the unrest is related to this crisis, or do you see it as a completely separate issue, Emily, and that's not but of less relevance to the topic that you're discussing now?
So I think that's a really interesting question. So I took part in an event for the Royal Society of Medicine, Mayo Clinic, etc., which is actually sponsored by a philanthropist whose very concern was this, who's been looking at social history in times of social unrest and political change, and how mass global stresses predict that. So this was exactly there, and I'll send you the link to that, Eric, because I can't remember the link off the top of my head. But I guess I feel like I'm no expert on that, but I do think that's exactly the kind of, by pulling out, like, if we think biopsychosocial, like we need a structure in which to place our thinking, whether it's clinical or scientific. So at the social level, we will be also thinking about history and structures and politics and support, which is ironically why when I think about mental health interventions, it may involve something like healthcare benefits or economic packages, not just psychiatric or psychological treatments. And that links all the way up social unrest. But having said that, as a scientist, I still think that's part of a mechanistic model where having a dialogue rather than just and thinking thoughtfully about this is the way forward. And I want to pull back because I have a few more slides and I'd love to have a debate around some of these issues.
I
Is
didn't want
that
to be
okay?
disruptive. I didn't want to be disruptive in the order of your slides. How many minutes?
Oh, no. I love questions, but actually we could pick up this, and I can see that Joseph has a question. I have tons of slides, but I'm going to skip through a few because I want to end on some ethics stuff, which I think will actually be very important to what you just said. So shall I do that? Shall I just, if the audience doesn't mind, I'll
Sure.
skip, because we're having a
Sure.
discussion instead, I'll skip through some of the stuff on my stuff.
Good.
And actually, I was just about to talk about, and we're going to have Irina's marvelous talk in a moment. He's been thinking a lot about how we act how you respond under pressure. But I guess pulling back in my stuff, and I'm just going to say, I'll share papers with whoever's interested, a bit like Isaac. So this is not, because we've just been talking, I don't have the time to go through some detail, which is perfectly fine. But the question might not be whole disorders. It might be what predicts ill health. And I'd recommend this paper where we try and spell out the idea, inspired actually by discussions from the Odessa meeting among others, of how we could work at different levels to take one symptom we could work on and manipulate that causally, as it were, change its frequency to bring about ideas. Because one of the problems we're having in science is the problems seem too big, the solutions are too complicated. Can we just get a little bit back down to simplicity, whether it's loneliness and an intervention for that, or our particular interests of our group are intrusive memories of traumatic events? Can we take a modifiable mechanism and bring that down? So really, this is the most important slide. What do you do in a complicated situation? Well, I guess what I've always thought clinically is try and make it simpler. This work you can find in our homepage, but it's going back to Isaac's point, the mechanisms could be, like the elegant work from Joseph's lab as well, any level, molecular, social, behavioral. And I'm not going to go through this now, but the kind of things that we're interested in are really disseminable tasks that are pretty language free, that you could do involving computer gaming to reduce the number of intrusive memories. But that's all beautifully written up. The lead author here is Laura Singh in this paper that's just come out last week. So I'm happy to share that in the chat. But I think it brought me back to the question of, if we're doing research and trying to help, can we start doing intervention questions that could be used at scale in a pandemic? That would seem like a savvy thing to do, particularly if this isn't going to come away tomorrow, which I don't think most people think it will. That one you can download for free. But I really appreciate, Eric, you bringing us together, because the questions are big right now. So we need spaces to think and talk. And within that, I think our ethical values need to be very, very clear. So I've already talked about equal respect for participants and community engagement, even in the most basic of sciences right now, that we try and think about issues such as fairness and of course the mental health reducing suffering. But alongside that, the ethics of hope, collaboration, and interestingly, that technology this is an opportunity to bring people together in this time. So I'm very, very happy to widen out and talk more about that. But I hope this slide in particular helps in the discussion point that you raised, Eric.
Well, thanks for doing this. And again, we can unmute for a second to give you a big hand, and then we can mute again. No, but this is wonderful. And if you stick out your head with writing this beautiful paper that you did in Lab Psychiatry, I think you're positioning yourself to be the spokesperson to direct our mental health research. I have lots of questions, but just to point, we're not going to address them all. We're dealing with a lot of conspiracy theories and mental health, and people are coming delusional about this, especially maybe the vulnerable population. I see the role of the media. I see new ways of delivering care with all these mental health institutions have to transform their infrastructure to deliver care in a completely novel way, and keeping up the pay for paying their personnel and getting their income from the insurance companies. The role of the WHO, the role of the CDC. Lots of questions, but maybe I'll direct the question to the other panelists, and you pick a few or so that you would like to comment on as we move on, Emily. Because
I'd love to answer it, and I'm just very grateful to all of my co-authors. I'm very happy to speak on this topic, but I see it very much as a shared dialogue between all of us at this point in time.
Joseph, you have
Emily. Yeah.
Hi, Joseph. Great to see you.
I would like to get your feeling about, this finding that there was decrease in suicide in the first couple of months, and now it's like it's picking up again.
Yeah.
And the explanation has to do with, and I think it was mentioned by Isaac, the cohesiveness of the society, how well the society is together and how, they are apart. And I think in this regard that we need to take into account, again, the timeline. What is happening in the first couple of months might be totally different from what is happening later on. And we need to find more explanation. And as I mentioned, one of the explanation was to do with the societal structure and confidence and cohesiveness. I would like to get your thought about this.
Absolutely. As I said, I think we have short-term priorities, or what we call immediate priorities, and longer-term priorities about trying to ascertain issues such as suicide. I mean, I think Rory O'Connor was one of the suicide experts working on this position, and from his work, I understand that it's the longer-term phases, and particularly we know that risk of suicide can be associated with economic decline. So I think one of the things to be concerned about is the impact of a pandemic on the economy, and the impact of the economy on pressures on people and these kinds of outcomes. So this is a long haul question. I don't think even the first few months are that's still short term in this particular field of inquiry. And I'm sure cohesiveness has got something to do with that as well. It's multifactorial models, but the big factors that we know over time, like the Great Depression, for example, is when the economy really hits.
Yeah.
Thank you.
One more question, and then I will leave the other people. We did a study on PTSD, on OCD, and we focus on individual with contamination and washing ritual and all of this. And we asked them how much the corona penetrate their OCD.
Yeah.
Zero in the first couple of months. There was, almost, like 95%, there was no any exacerbation, and the obsession or compulsion or ritual was totally not related to the pandemic. Any thoughts about this?
Yeah. We had somebody in OCD working on this paper. So Ros Shafran was one of the co-authors, and we actually took out OCD discussion from the paper because when we talked to people with lived experience, they were quite well able to distinguish. So I think that might be the kind of thing mental health professionals think, hand washing. But if you talk to people with lived experience, for some it's an issue and for some it isn't. And again, it goes back to mechanisms and what's driving a particular behavior like hand washing. So that it absolutely illustrates the importance of working with people with lived experience of mental health.
Thanks again. I'm looking here at my thumbnails here. If there's any additional question from Irina, David, or others, then we'll look at the clock. And thanks again, Irina, for sharing this knowledge that you built up in designing this paper and delivering this paper, and we'll probably hear much more. And just want to highlight this word you didn't call the cognitive vaccination model, and you alluded to it briefly. That was a highlight of your work that is of relevance. And you skipped some of the slides, but you're
Can you
able.
still see my slides? I put one up just.
Yeah, we can. Yeah, memory. Yeah. Which in the golden hour perspective is really a beautiful piece of work that you intertwined in between your slides.
Thank you so much. And I would love to hear, particularly with just reflections and critical thoughts from the younger people around Europe, or I should say early career people around Europe, about increasing this dialogue as we all learn together. So I hope this network is a useful forum for that.